Right. Hi guys. Good evening. Good evening. Good evening. Can you all see me? Can you all hear me? All right. Yeah. I hope you all joined in. Good evening, guys. Good evening. All right. So, hi guys. Good evening. Welcome to another series of BLS. Today, we're continuing on the esophagus. This will be the last week where we'll finish the entire esophagus. Today, we'll be talking about another topic in the esophagus, and yes, I hope you all have joined in. Quick feedback. Let me align the colors as well. Okay. All right. So today's topic that we're going to talk about is going to be about one of the very interesting topics is hiatus hernia, right? So we need to understand the concept behind these. So we'll try to understand what is a hiatus hernia. We'll talk about hiatus hernia. We'll talk about the hiatus hernia and the paraesophageal hernia. And the paraesophageal hernia. Again, the terms are quite interchangeable. There are small bit of understanding that you need to have before we dig deep into this, right? So when we talk about the hiatus hernia or the paraesophageal hernia, let's try to understand that what it basically comprises of, right? So talking about a hernia or a content that is, we have already dealt a lot about hernia, right? We have had a huge discussion with the hernia before, but this is going to be in terms of your abdominal components, right? तो इससे पहले भी हमने hernia के बारे में बात किया था कि any content that goes through an anatomical weakness to another cavity. It could be an external cavity, it could be into the abdominal wall weakness, it could be from abdomen to a thoracic cavity. All that will be considered as hernia. Now, in order to have a good understanding about the hiatus hernia, what hiatus are we talking about? We're talking about diaphragmatic hiatus, that is the weakening in the diaphragm. So, quickly understanding that what is there in diaphragm. Now, I know that you would have had a very good detailed discussion of the anatomy of the diaphragm in your regular anatomical lecture, but from a surgeon's perspective, I want you to know that what is relevant for us in the form of diaphragm, right? So, when you talk about the diaphragmatic component, I'll say this happens to be the entire costal margin, that is going to be the ribs that we are talking about. On the posterior most section, I would say that you will have vertebra dead in the center. So let's say this happens to be the vertebra, just for the sake of understanding. We're talking about the lumbar vertebra that is going to be present across here. So we say this is the L1, this is the L2, this is the L3, this is the L4. I've just kept it across, right? Now, on the either side, you will see there are two sets of muscles which are going to be present. So we're going to be using these as the two sets of muscle which are going to be guiding our purpose, right? So there are two sets of muscles which are going to be present in these components. You will notice that the diaphragm that is going to form and attach will start its attachment. I'll say it starts its attachment on the anterior most surface. On the anterior most surface, let's say we have the xiphoid, right? So this is for the sake of understanding. I'm just creating a xiphoid. Now you will notice that the diaphragm which is going to attach, it is going to attach throughout this component through the costal margin, or I can say through the costal cartilage, and it continues across here, right? And then it is going to arch over these muscles. It is going to arch over these muscles, and then it is going to run medially. Now, as it runs medially, you will see in the center component, dead in the center, you will see a tendinous insertion that is present, and this is what we call it as the central tendon. right? So dead in the center, in the diaphragm, you have a central tendon that is present, right? So within this tendinous insertion, you will see that this diaphragm will have a muscular component, right? So this is how a muscular component would look like. We'll detailed a bit of this. This is what we call as the crus of the diaphragm, and this will continue and this is going to attach onto the vertebra, right? So this is the crus of the diaphragm on the either side, the left and the right crus which is present. This is the muscular component, right? Now if I just need to highlight, this is the entire diaphragm that you're looking at. This is the entire diaphragm that you're looking at, and this boils down to develop into the crus of the diaphragm, which is going to arch over the muscle fibers, right? So try to understand what is the objective. But this is how the diaphragm is going to look like. Now this is very important for us to understand the attachment of the diaphragm, its insertions, and how it is going to play around with its surrounding structures, because if you understand this as a principal component, then my job to explain you the hiatus hernia or the diaphragmatic hernia becomes quite simple. So this is how the diaphragm would look like. Dead in the center, as I told you, we will have the central tendon. So this is the central tendon which is present across here, right? This is going to be present across here, right? Just for the sake of understanding, if I just label them across, the anterior most is going to be xiphoid. This is going to be the xiphoid. The attachment which is here in the diaphragm, we call this as the sternal portion of the diaphragm. So this attachment that you can see here, if I just highlight this, this is what we call it as the sternal portion of the diaphragm. This would be called as the sternal portion. This is what we call it as the sternal portion of diaphragm. This dead in the center is your central tendon. This happens to be the central tendon of the diaphragm. This is the central tendon of the diaphragm. Now you would notice here across, this will have a lumen that is going to be for the esophagus, and the crus is going to cross over a bit. So this is the esophageal hiatus that is created, and just under this you have the aorta. You have the aorta that is going to be present, and in the area of the central tendon here you have your IVC. So let's say the IVC which is going to be present is going to be here. So this is going to be the IVC, right? So three structures which are going to be present. You have the IVC, the esophagus, and the aorta in the same orientation that we have put across here. Now for the sake of understanding, if I just highlight this area, this is what we call it as the crus of the diaphragm. This would be called as the crus of the diaphragm, which is here. So this is the exact condensation that you will see, the right and the left crus of the diaphragm, right? Okay, so we have the central tendon that we have just marked it across. Along with the central tendon, we have the left crus and the right crus. This happens to be the left crus. This happens to be the right crus. This happens to be the right crus. The left and the right crus is right across here. This is your inferior vena cava, which is here. This happens to be esophagus. So if I just put it across it, this is your esophagus. This happens to be your aorta. The two muscles that we are talking about, one is going to be psoas, another one is going to be quadratus lumborum. The one which is present on the lateral side is your quadratus lumborum. It is your quadratus lumborum. And one that is present medially, this is going to be your psoas muscle. This is going to be a psoas muscle. Now you see there are 3 ligaments which are going to be present, right? If I just highlight that, I need to find a color so that I can make it more distinctive. Okay, we'll use the green color here. Now you can see there will be 3 ligamental attachments which are going to be present, which is going to be one that is covering the quadratus lumborum, one that is covering the psoas muscle, one that will be covering the aorta, and then you have the same on the other end, right? So this is the coverage of the ligament that is going to be present. So we're just going to name them. When you look at this, this is what we call it as the lateral most structure. This is your lateral arcuate ligament. This is your lateral arcuate ligament. This is going to be your lateral arcuate ligament. Obviously, the one which is present medially, this is going to be the medial arcuate ligament. This is going to be your medial arcuate ligament. And the one that is covering the aorta is what we call it as the median arcuate ligament. This is what we call it as the median arcuate ligament. This is what we call it as the median arcuate ligament, right? So this is the basic orientation of the diaphragm that you need to know, that is from all the aspects, right? So when you look at the entire diaphragm, there are 3 openings which are present in the diaphragm, right? If I keep it very simple, the opening number 1 is going to be here, the opening number 2 is here, and the opening number 3 is here. So what are the 3 openings? You have the IVC, you have the esophagus, and then you have the aorta, right? So when you look at the orientation for this, if I have to give them as an objective, remember the IVC is the first one to open, then you have the esophagus, and the last one is going to be aorta. So when you look at this, IVC is going to be at the T8 level, esophagus is going to be at T10 level, aorta is going to be at T12 level, right? So these are the levels at which you will see that the structures are going to pierce the diaphragm. The diaphragm is pierced by IVC at the level of T8, esophagus at the level of T10, and the aorta at the level of T12, right? So this is the basic orientation of the entire diaphragm that you need to have, right? Now what is interesting is when you talk about a hiatus hernia, that is weakness is surrounding this area, that is right in the left crura, or the hiatus gets weakened, so the content will start to herniate from here, right? That's what we call it as the hiatus hernia, right? Now in order to understand the whole concept of hiatus hernia, just a little bit of more extension into what we have been learning completely, right? So let's say this happens to be the esophagus, we've been talking about it. The esophagus is going to continue into the stomach, nothing spectacular about it. So this is going to be the stomach that we've been dealing with. Next we say that we have the diaphragm which is going to be present. Let's say I'm going to give you an objective as diaphragm. So let's say this happens to be the diaphragm. So I'm saying this happens to be the diaphragm that is going to be present. Just for sake of understanding, let's say this is the diaphragm that we are going to talk about, right? So this is the diaphragm. So above this diaphragm you have esophagus, below that you have the gastroesophageal junction and the stomach which is going to be present across here, right? Now when you look at the entire concept of the diaphragm, let's say this is how a diaphragmatic muscle would look like for the sake of understanding. Now I'm going to make it a little bit bulkier, right? So this is how the diaphragm is going to look across here. So let's say this is the diaphragm that is present, right? Now from the undersurface of the diaphragm that you can see, you will see there will be one structure which is going to be coming from the stomach, or it is covering the stomach in total, and I need not tell you that this structure is going to be the peritoneum, right? So see from here you see the peritoneal cover will be there in this particular manner. So this is how a peritoneal cover is going to look, no doubt about it. At the same time, we have another membrane that is called as the frenoesophageal membrane or the frenoesophageal ligament, which arises from the undersurface of the diaphragm. It goes and merges with that of the peritoneal surface on the stomach side, right? At the same time, it is now going to go and merge onto the esophagus above. Right. You see there is this structure which is going to arise or attach to the under surface of the diaphragm. It comes and then attaches to the esophagus, goes down and combines with that of the peritoneal surface, right? It is now combining with the peritoneal surface of the stomach and then continues as well, right? So this merges off. This basically is going to merge off. If I give you the objective, this is how the peritoneum is here. This is going to merge off with the peritoneum in this particular fashion, right? This is going to merge off with the peritoneum and this is present all across here. Now this membrane that we're talking about is what we call it as the frenoesophageal membrane, or you can simply call it as the frenoesophageal ligament as well, right? This is going to be your peritoneum and this happens to be your diaphragm. Now, as you all know, we will not discuss anything which is not going to be relevant from our discussion point. So, this is going to be very, very important. This is going to be your very, very important, right? So, just for the sake of understanding, if I just highlight this area of frenoesophageal ligament, this is how it would look like. So, this is your frenoesophageal ligament. And this is the esophagus. Okay, great. So, breast anatomy video not available, but a breast anatomy video should be available. If it is not available, we'll ask the team to put it across. Okay? So, don't worry. Now, this is the basic objective of knowing about the diaphragm and its attachment. Now, let's go into our core topic of the hiatus hernia. Now, when it comes down to the hiatus hernia or the paraesophageal hernia, so we'll be dealing with both the components. We have the hiatus hernia as well as the paraesophageal hernia. So, our job is to understand and differentiate both of them. It is to understand and differentiate both of them. Right. So, let's get this into component. Now, to understand this, let's have a basic objective that we've been talking about. It is going to be the esophagus and this is going to be the stomach. We'll have certain markings so that we don't confuse ourselves. This is going to be the diaphragm. This is going to be your gastroesophageal junction. This is going to be your gastroesophageal junction. Okay? So, for the sake of understanding, if I just quickly give a labeled part, this happens to be esophagus. This happens to be diaphragm. This happens to be stomach. And this is your gastroesophageal junction, right? Now, there are different varieties of the hiatus and the paraesophageal hernia. The first variety or the type 1 variety, right? So, we have the first variety which will be called as the type 1 variety. The type 1 variety is what we call it as the sliding hiatal hernia. This is what we call it as a sliding hiatal hernia. This is what we call it as a sliding hiatal hernia. So, what is the concept in the sliding hiatal hernia is, you will notice that if this is the representation of the esophagus and this is the stomach, you will see that this is the site of the gastroesophageal junction. I'm just going to mark it down. This is the normal site of the gastroesophageal junction, and let's say this happens to be the diaphragm that is present. Due to any reason that we'll be discussing in a bit, if this migrates upwards, if the gastroesophageal junction moves upwards and goes above the level of diaphragm. If it goes above the level of diaphragm, you will notice that if this happens to be the esophagus, this is the gastroesophageal junction that you are seeing across here, and the diaphragm is going to be below this level, and then you see the stomach has moved across here. So diaphragm is now going to be at this position where it is compressing. The gastroesophageal junction, which was down, is now moved upwards. Now this movement of the gastroesophageal junction, which was intra-abdominal, is now moved into intrathoracic space. This is what we call it as the sliding hiatal hernia. So when I say sliding hiatal hernia, it is the cranial migration of the gastroesophageal junction from the intra-abdominal cavity into the intrathoracic cavity. So what is your sliding hiatal hernia? It is defined as the cranial migration. It is defined as the cranial migration. It is the cranial migration of gastroesophageal junction from intra-abdominal cavity. From the intra-abdominal cavity into intrathoracic cavity. Into an intrathoracic cavity, and this is what we call it as the sliding hiatal hernia, or also called as the type 1 variety of the diaphragmatic hernias, right? So this is in the context of sliding hiatal hernia. Now there is something called as type 2. Now type 2 is what we call it as the rolling hiatal hernia. The type 2 is what we call it as the rolling hiatal hernia. This is called as the rolling hiatal hernia, or also referred to as the true paraesophageal hernia. This is also referred to as true paraesophageal hernia. Also referred to as a true paraesophageal hernia. Let's understand what is the basic concept behind it. So when I say type 2 variety, in a type 2 variety, you will notice everything remains the same. We'll try to give the same analogy to understand. Let's say this happens to be the esophagus, this happens to be the stomach, and we have determined that you have the diaphragm which is present here. So this is the diaphragm that you have, and this happens to be the gastroesophageal junction, which is intra-abdominal, which is considered to be normal. Now, as you know, around the esophagus, the diaphragmatic crura, which is present in the left and the right crus, which are going to anchor the entire component of the esophagus so that it does not move away, right? Now, imagine if one of the crus is going to become weaker. Let's say if one of the crus is going to become weaker, and I can say there is a small defect that is now created at the level of crus. There is a small defect which is created at the level of crus, and we all know inside the thorax we have the negative pressure, right? So intrathoracic pressure is a negative pressure, and we all know negative pressure is a pulling pressure. We all know negative pressure is a pulling pressure. Now under the influence of that pulling pressure, the stomach will now be pulled into the intrathoracic space. Now if the stomach is going to be pulled into the intrathoracic space, you will now notice that if this is the esophagus which is present, from this opening you see the fundus of the stomach is going to go into the intrathoracic space. The fundus of the stomach is now going to go into the intrathoracic space, and you will see across here. So this is how you will see the rolling hiatal hernia is going to occur. Now a couple of important things, that the gastroesophageal junction. The gastroesophageal junction still remains in the intra-abdominal space, right? But the stomach is going to protrude, or the stomach is going to invaginate, or a part of the stomach invaginates into the intrathoracic cavity. This is what we call it as the rolling hiatal hernia. So in the rolling hiatal hernia, just give me 1 second, guys. Excuse me. Alright guys, so as I was saying that in a rolling hiatal hernia, the part of the stomach is going to invaginate into the thoracic cavity, right? Now, as we all know, in that context, there are two things that you need to know. In a rolling hiatal hernia, a part of the stomach, it is most commonly the fundus of the stomach. Most commonly the fundus of the stomach, it is going to migrate. So part of the stomach migrates into the thoracic cavity. Through a weakening in the diaphragm. This is what we call as a rolling hiatal hernia. Now, another criteria for rolling hiatal hernia, that the gastroesophageal junction remains intra-abdominal. It remains intra-abdominal. This is not going to migrate. This will not migrate. So, you see the gastroesophageal junction which is present here. The gastroesophageal junction. The gastroesophageal junction remains intra-abdominal. It is not going to migrate. It remains intra-abdominal, but the stomach is going to push away, and that is under the influence of negative pressure. This is going to move. Under the influence of negative pressure, it is going to move, and this is what we call it as the rolling hiatal hernia. This is what we call it as a rolling hiatal hernia. Right now, there is a special term that we use which is called as a massive rolling hiatal hernia. We call it as, the word is called as the massive rolling hiatal hernia or a giant rolling hiatal hernia. So, when I say a giant rolling hiatal hernia, what is the criteria? For a giant rolling hiatal hernia, remember, more than 50% of the stomach has to invaginate into the thoracic cavity. Then we will call it as a giant rolling hiatal hernia. So, for a giant rolling hiatal hernia, more than 50% of the stomach, is pulled into the thoracic cavity. It is pulled into the thoracic cavity. It is more than 50% of the stomach is pulled into the thoracic cavity, and this is what we call it as the giant rolling hiatal hernia. Clear? So, this is about a type 1 and the type 2 variety, which is quite understandable, right? Then we have something called as the type 3 variety. Let's understand that as well. So, what is a type 3 variety? Now, a type 3 variety is going to be called as a mixed hernia. So, it is called as a mixed hernia where you have both components of sliding as well as rolling. It will have a component of both sliding as well as rolling, and this is also, because rolling component is there, I can say this is a variety of the paraesophageal hernia. So, this is a variety of a paraesophageal hernia. So, the component of rolling is there, so hence it will be called as the paraesophageal hernia, right? Now, you need to understand what is going to happen. Now, everything remains the same. We are going to do the same drill that we have been doing. We have the esophagus, it goes into the stomach. Now, they are separated by this diaphragm which we have been vouching for a while. So, this is the diaphragm which is present across here. This is the gastroesophageal junction that we are talking about. According to our sliding hiatal hernia, the G junction is going to migrate cranially, and according to our rolling, the part of the stomach should invaginate into thoracic cavity if both of them are going to occur at the same time, right? If both of them are going to occur at the same time. Now, you remember I told you in a rolling hiatal hernia, the G junction remains intra-abdominal, but sliding it migrates up. So, combination of these two will put us into type 3 variety, which is going to be mixed. Now, you will notice that in a sliding hiatal hernia, this G junction has migrated up. This has now created a new component. The part of the stomach is invaginated across here, and then you see the stomach is going to be continuous across, right? Now, when you see this as the component, you now see that this is how it is going to be present. So, this is the gastroesophageal junction. Now the G junction, as told, has now migrated into the thorax. The part of the stomach is also migrated into the thoracic cavity. A combination of both sliding and rolling put together is what we call it as the mixed variety. This is what we call it as a mixed variety. So have a composition and a clear-cut consensus that a mixed variety is a composition of two, right? So in a mixed variety, you do not tell you that you have a combination of both. The last one that you need to understand is going to be your type 4 variety. The last one that you have is going to be a type 4 variety. Now type 4 variety is what we call it as the complex variety. This we call it as the complex type. Now why are we calling it as complex? You will see that there will be an intra-abdominal content herniating into the intrathoracic cavity, but this time it is not going to be stomach. So anything else than stomach if it herniates, right? So we call it as any other viscera except stomach. Except stomach. Any other viscera except stomach herniating into thoracic cavity. Into thoracic cavity. Into the thoracic cavity would be called as a type 4 or the complex variety. Now what could be that type 4 or complex variety basically determined, right? Again, we have the same orientation. We have the esophagus, we have the stomach. Now we have the duodenum, which is going into jejunum. Jejunum goes into ileum. The ileum goes into appendix, then to cecum. Then you have the ascending colon, which is going to be here. Then you have the transverse colon, which is going to be here. And then you have the descending colon, which is going to be here, the sigmoid colon, and obviously the rectum, the anal canal, and everything. As we all know, this is now separated by the diaphragm. Now what did I tell you? That anything else than stomach. So if you look logically, obviously I have one organ which is going to be present here. This organ is going to be spleen. I can say the spleen can also herniate. I'm not going to argue that it cannot, but usually the bowels are more easily available. So let's say there is a defect which is present here. So what it does is it allows the bowel which is present here, usually the colon, to go into the space. Right, to go into the space. Now if it is going to go into the space, how would it present to you? Everything remains the same. You have the esophagus, right? You have the stomach. You have the bowel which is present. You see, this time this is going to go like this. And the rest of the bowel continues, right? And you see this is going to be in this particular form. So diaphragm stays across here, and you see, as if I highlight, right? If I highlight what has happened, this was the colon that was moving across here. Now you can see the same colon is now gone here now, right? So as we have described, in a type 4 variety, we call it as a complex variety because now the component which is going to herniate into the thoracic cavity is anything else than stomach, right? Now this is what we call as type 4 variety. So we have 4 varieties that we have discussed in the context of your hiatal hernias, right? What are the 4 varieties? The type 1 variety is what we call as sliding, where only the gastroesophageal junction is moving up. Type 2, it is rolling, where the stomach goes but the gastroesophageal junction remains in its position. Then you have the type 3 variety. In a type 3 variety, you will have a combination of both sliding as well as rolling, and type 4 is what we call it as the complex variety, right? In a complex variety, the component which is going to herniate is going to be anything else than stomach. As simple as that. Nothing spectacular, nothing more, nothing less, right? Now understand the question and try to answer, and this is how they ask you if you are preparing for your competitive exams. Now if you are a NEET student or a NEET PG preparing student or an INICET preparing student or an FMGE student, you need to know these answers. The question number 1 is, which is the most common hiatal hernia? Now you require, when you talk about the hiatal hernia, we have all 4 varieties, right? So hiatus hernias is going to be the type 1 variety, type 2 is also hiatus, type 3 is also hiatus, type 4 is also hiatus. Now the concept of hiatal hernia is, if anything is going through the hiatal opening, that is the diaphragmatic opening. Okay, so all four varieties are called as hiatal hernia. So in this, the most common variety is going to be your type 1 variety, which is going to be around 85 to 90% of your entire hiatal hernia is going to be a type 1 variety. There is no argument at all. Now if I change the question and ask you which is the most common type of paraesophageal hernia, what is the most common type of your paraesophageal hernia? Now here, paraesophageal means the content has to go through a weakening and it should get into the thoracic cavity. So there has to be an organ, a true organ that is going to herniate. So if you look at the paraesophageal hernia, only the type 2 variety, the type 3 variety and the type 4 variety is what we call it as the true paraesophageal hernias. They are the one which will be called as the true paraesophageal hernia. So if you look at this, the most common type is going to be your type 3 variety, which is going to be a mixed variety, right? So do not goof up on that. If they want to make your life difficult and they want to ask you questions which are going to be tricky so that you will not be able to crack an exam, I am there for you to understand and get you help. These are the questions that they ask you, right? Obviously, they cannot make it more difficult. They cannot have a life which is going to get more trickier than this. So this is what they'll ask you. Most common type of hiatal hernia, most common type of paraesophageal hernia. You need to understand the type 1 does not categorize as paraesophageal. The other 3 categorize as paraesophageal, but all 4 is called as hiatal hernia. Okay? Now this is a concept that you have to remember till you die. Okay? Clear, guys? Clear? Chalo. Wait, need to get some water. Chalo. So let's talk about the clinical presentation of all these hernial components that we have. So talk about the clinical features of hiatus hernia. We talk clinical features of the hiatus hernia. Now, in order to understand all the features of hiatus hernia, we are going to do a comparative study, right? So in the comparative study, we'll be talking about all the 4 varieties of the hernias that we had. So we'll talk about the type 1 to type 4 varieties. So we'll talk about between type 1 to type 4 varieties and how did they present to us, right? So we'll talk about how did the type 1 hiatal hernia presented to us. We'll talk about its clinical presentation and its management. We'll talk about the type 2 variety. We'll talk about the type 3 and the type 4 variety, right? So we're talking about all 4 varieties of the hiatus hernia that we had. So we had the type 1 variety. We had the type 2 variety. We had the type 3 variety. And then we had the type 4 variety, right? So as we all know, nothing spectacular about it. Type 1 variety is what we call it as the sliding hernia. So, okay, just to make it more understandable as one particular table, we'll add another column of characteristics. So we'll add one more table of just the characteristics. Okay. So in each individual types that we're talking about, the type 1, type 2, type 3 and type 4. The first thing is in terms of the what are their characteristics or let's say names. Type 1 is what we call it as the sliding hernia. Type 2 is what we call it as the rolling hiatal hernia. Type 3 is what we call it as the mixed variety. This is what we call it as the mixed variety. And type 4 is what we call it as the complex variety. It is the complex variety. Now, we'll try to understand what is happening to the gastroesophageal junction. In type 1 variety, you notice the gastroesophageal junction is going to go into the thoracic cavity. So, this is going to be intrathoracic. Here it is going to be intrathoracic. Type 2, it is going to be intra-abdominal. This is going to be intra-abdominal. Type 3, it will go into thorax. It is going to be intrathoracic. In type 4, it is anything else in stomach. So, the GE junction will remain in the intra-abdominal space. This is going to be intra-abdominal. This is going to be intra-abdominal, right? Now, when you look at the components of each variety, we say what is the most common content to herniate. Because of hernia, you need to know the content. The most common content to herniate. So here you can see the intra-abdominal esophagus is becoming intrathoracic. So the most common content to herniate, here we'd say it is the intra-abdominal esophagus. It is the intra-abdominal esophagus. It is the intra-abdominal esophagus with cardia of the stomach. With the cardia of the stomach, usually herniate. Here it is going to be the fundus of the stomach. It is the fundus of the stomach. Here it is the component of both, that is the intra-abdominal esophagus. Intra-abdominal esophagus with cardia of the stomach. With the cardia of the stomach with fundus of the stomach. With the fundus of the stomach. Right. Type 4 variety, it is usually going to be your transverse colon that is going to herniate, which is the most common. The other organs, it can be associated with spleen as well. It could be associated with spleen. Now, when you have all these components are going, the symptoms that we usually anticipate is the development of GERD, because if the hiatus is weakened, obviously the lower esophageal sphincter will get weakened. So whether there is GERD or present or not. Another one is going to be association with gastric volvulus. It is going to be association with gastric volvulus. The stomach that is gone can rotate or not. Now remember, GERD is actually a predominant finding that you will see in sliding. In rolling there is no GERD, but with respect to your mixed, it will have GERD. There is no GERD here. There is no association with gastric volvulus here. The risk for gastric volvulus is present in these two. I will not say gastric volvulus, but as the content has gone here, there is no volvulus per se, but the obstructive features are present. So if you take another consideration as the features of obstruction, usually you will not see obstruction in your sliding, but the possibility of obstruction is present in the other three. So they can land up with the presentation of bowel obstruction. It could be when you talk about the stomach, stomach when it goes into your volvulus, what type of volvulus you're talking about? Yes, that's also very interesting. Now when you talk about the type of volvulus, when looking at the type of volvulus inside the stomach, there are two varieties. One is going to be the organoaxial, another one is the mesenteroaxial. It is more common as organoaxial. It is going to be more common as organoaxial, right? So when I talk about what is this type of rotation that you're talking about? Let's say if you take this as a representation of the stomach. So this is the esophagus, and let's say this happens to be the orientation of the stomach, right? So when you take at the long axis of the stomach, this is the long axis of the stomach, and if the stomach rotates around this is what we call it as organoaxial. This is what we call it as the organoaxial rotation. This is what we call it as the organoaxial rotation. On the same hand, if it rotates around its mesenteric axis, let's say if this is the esophagus and this happens to be the stomach which is present here, and this is the mesenteric axis which is present, and if the stomach rotates like this is what we call it as the mesenteroaxial It is the mesenteroaxial rotation. So here it is the organoaxial, which is more common when compared to mesenteroaxial rotation. When compared to a mesenteroaxial rotation, right? So when you look at the clinical presentation, the type 1 variety usually present you with features of GERD. The type 2 variety will have features of gastric volvulus, which will have obstructive features. Type 3 variety will have both GERD as well as obstructive. Type 4 is usually going to be with the obstructive features or the bowel obstructive presentation that you have. Now, especially when you talk about the type 2 and the type 3 variety, where you are having the stomach is getting compressed between the components, right? So as you can see here, I'll just go back here. In type 2 variety, let's say this is the wall of the stomach. Just for the sake of understanding, I'm just going to make it a bit more dramatic. This is the wall of the stomach. Obviously, the blood supply is going to come from the mesenteric side, which is going to be from this side, right? So this is the supply of the blood which is going to go. Now, if the stomach is going to get compressed, obviously the blood supply to the wall is going to become less. So it will result in ischemia of this particular site. That ischemia can result in ulceration, and this ulceration which develops because of the compressiveness causing hypoxia and ischemia in that area of the bowel or the stomach. This is what we call it as the Cameroon's ulcer. This is what we call it as a Cameroon's ulcer, or also called as the Riding's ulcer. Also called as the Riding's ulcer, and this can present to you with upper GI bleed as well. So patient can present you with hemoptysis, hematemesis. The patient can present you with hematemesis, right? So Cameroon's ulcer are usually seen in these conditions where you have a rolling hernia, right? So it can be present here. You can have in type 2 variety, same concept. So here also you can have presentation of Cameroon's ulcer. Here also you can have presentation of the Cameroon's ulcer. Because of poor vascularity, right? Because of the poor vascularity, right? So these are the various types of the hiatal hernia, their clinical presentation, right? Now, if you want to evaluate, remember in terms of investigation, see, when you talk about paraesophageal, they are usually incidentally found, but then your sliding will present you with features of GERD, no kidding about it. So here what you can do is you can perform an upper GI endoscopy. You can do a contrast imaging, that is going to be your barium swallow. You can also do a CCT of thorax and abdomen. This is going to be CCT of the thorax and abdomen. So if I show you a contrast image, if I give you a contrast image, this is how the contrast image would actually look like. So if you observe carefully in this contrast image, this is what we call it as the type 1 variety. This is your type 2 variety, and this is your type 3 variety, right? So what can you see in type 1 variety? In the type 1 variety, you can see that the stomach, which is now, this is the gastroesophageal junction, which should have been below the level of diaphragm, which is present here, along with the part of the cardia, is now pulled into the thoracic cavity. It is sliding. You can see a part of the stomach is invaginated in the thoracic cavity. This is going to have an air bubble in the thoracic cavity, usually in the cardiac shadow. So there will be an air bubble within the cardiac shadow. That is going to be a type 2 variety. If you have the gastroesophageal junction, you see here the gastroesophageal junction is now moving up, and the part of the stomach is also invaginating. So hence it is considered to be as a type 3 variety, right? So you have the type 1, which is the sliding variety. This is sliding variety. This happens to be the rolling variety, and this happens to be a mixed variety, right? So based upon the image, that becomes quite clear. Okay. Now, how would you like to manage? So in terms of management, in the management, we have a type 1 variety, we have the type 2 variety, you have the type 3 variety and the type 4 variety, right? Now, each individual has to be tailored, but we'll have a comprehensive understanding for all of them. Type 1 variety, because again, a very beautiful concept in type 1 variety is, it could be because of the weakening at the level of diaphragmatic hiatus, but it can also be because of GRD. So we say a type 1 variety may or may not be because of GRD, but every patient of type 1 variety will present you with GRD. So here in type 1 variety, you have to provide with anti-reflux. You have to do a anti-reflux surgery. And this anti-reflux surgery is basically fundoplication. You have to do a fundoplication. Anti-reflux surgery has to be done. You have to reduce the content. You have to reduce the content into the abdomen. So pull that gastroesophageal junction back into the abdomen, do a fundoplication and also repair the defect. So there are 3 goals that you have in type 1 variety, which is going to be this, right? But all these images are of contrast, that is going to be barium swallow. All these 3 are barium swallow images, not CT images. Okay. The other 3 varieties that you have, when you look at collectively as the management goal, the first thing that you have to do is to reduce the content. Reduce the content into the abdomen. Number 2, repair the defect. Number 2, repair the defect. And third, in type 3 variety, perform anti-reflux surgery also. Do a anti-reflux surgery also, right? So this is how you're going to manage your hiatus hernia or the paraesophageal hernia, right? So all these are what you need to be taken care in the context of paraesophageal hernias. Okay? So again, when you look at the hiatus hernia or the paraesophageal hernia, they're a little bit tricky because that's the anatomical orientation and understanding that you need to have. From where is it coming out, how it is coming out, what are the contents, when do you call it as hiatus hernia, when do you call it as paraesophageal hernia, what are the different varieties. So we try to summarize in the best possible way. This is the table that you need to remember in the context of the presentation and its implications that we are going to look across, and obviously this diagrammatic representation for type 1 variety, type 2 variety, type 3 as well as type 4 variety, right? So that's it for today. If you have any questions, any queries, you know where to reach out. We will have the notes sent to you straight after the class. You can get them on the PW Meded channel also, or on my own channel, that is the surgery guy. So any questions, any queries, just post it down there in the surgery guy. This is by my name, that is your Dr. Sandeep Sir. So any questions, any queries, you can post it here. This is the same handle that you have for the Telegram as well as for the Instagram, right? So any questions, any queries, just send it across here. Thank you so much, guys. Thank you, Raja. Thank you, Pratik. Thank you, Arvinant. I hope I pronounced your name correct, and Utpal as well. Thank you so much for all the love and support, and let's continue to do our BLS series. Today, I think we have done fair amount of esophagus. Tomorrow, I think, tomorrow there is no class because I have another YouTube session that is going to be for FMGE. Day after tomorrow, I think we'll finish off with the esophagus because we're only left out with esophageal cancers and its management. I'll try to wrap it up in 1.5 hours so that we finish it completely. What is fundoplication? So somebody is asking us fundoplication. That means he did not come to our GRD lecture. बेटा फंडोप्लाइकेशन क्या है, अरे ऐसे कौन पूछता है, फिर भी बता देते हैं, ठीक है. सो व्हेन यू लुक एट द फंडोप्लाइकेशन, this is what is fundoplication. You can see the stomach is wrapped around the esophagus so that it has good amount of integrity to regain that pressure component is what we call it as fundoplication. ठीक है. Alright, so thank you so much for joining today. We will resume back day after tomorrow with esophageal cancer. Until then, read what we have taught you. Any questions, any queries, you know where to get us. You'll get it on the PW Medit as well as on my personal channel, that is by the name Surgery Guy. Remember the name Dr. Sandeep Sir. Any questions, any queries, send down across. Until then, good night. Thank you. Bye bye.